So good evening, everyone. It is 6 o'clock and I'm happy to commence this evening's proceedings. My name is Dr. Marissa Nimrod. I'm president of the Trinidad and Tobago Medical Association, and the privilege is mine to actually host or chair this meeting this afternoon or this evening at the request of the Chief Medical Officer for Trinidad and Tobago, Dr. Roshan Parasram, and the officials from the Ministry of Health. So without much further ado, I would like to introduce our very distinguished, hardworking, dedicated, and always up-to-date public health representative and official, Dr. Roshan Parasram. He has been at the forefront and the face for the COVID epidemic, and as another event obviously presents a challenge to us in terms of education and awareness. We are quite honored to have him bring an overview and introduction to this evening's topic with respect to the monkeypox, which is the other newest public health concern. So without much further ado, Dr. Roshan Parasram, it's a welcome on behalf of the Trinidad and Tobago Medical Association, and thank you for inviting us to share this platform with you. So over to you.
Hi, good afternoon, everyone. Good afternoon to Dr. Nimrod, President of the Trinidad and Tobago Medical Association. Good afternoon to the presenters this afternoon, Dr. Jeffrey Edwards, Dr. Marilyn Sweet, and Dr. Avery Hines, who actually, if I may say, last week, Friday, I would have called Dr. Nimrod and Dr. Edwards, letting them know, of course, that we have the looming threat of monkeypox to the region. And we really needed to have an informed clinical group in Trinidad and Tobago to ensure that we're able to detect very early from a clinical perspective and diagnose monkeypox as it comes into the region. So it is something that has been detected for many years in West Africa and other parts of Africa and has become endemic in that part of the world. But what is new, I think, is that we're seeing multiple cases now developing in the non-endemic parts of the world. So WHO has indicated in their last update, which is June the 1st, that we now have 550 suspected or confirmed cases in 30 countries across 6 regions of the WHO world. So we're looking at a spread that has occurred very rapidly. We have, of course, the global village concept that is in place, and we live in uncertain times. And we see with COVID-19 how quickly diseases can go from one part of the world to the next. So with monkeypox, what has been ascertained so far from the WHO investigation, which is a retrospective and ongoing investigation that continues to bear some fruit in terms of the epidemiology of the epidemic as we see it go forward. But generally speaking, they have alluded to 2 possible point source events that occurred, one in Spain and one in possibly Belgium in their latest update, which of course those events would have had someone that would have been positive or suspected at the time carrying clinical symptoms, would have mingled in close contact with other individuals, and then thereafter those persons would have dispersed wide and far across the globe. And of course, once people move and they're infected, they take with them the disease that they get at that point. So it's called a point source infection, at least that's what we know so far. Hasn't been confirmed, but it is highly likely that it is 2 separate events that occurred in Europe and has led to some spread throughout the world. We expect that certainly in the region of the Americas and in the sub-region of the Caribbean, it's only a matter of time before we have suspected and possibly confirmed cases. My initial concern is that we need to have clinicians being able to recognize this disease very early. The manifestations, of course, just broadly fever, flu-like symptoms in general, but they have a rash as a particular, not diagnostic, but a particularly noticeable rash that tends to be the first presenting feature in most instances. So what has happened in other parts of the world is that you see this rash presenting in your STI clinics, you see it presenting in your dermatology clinics, primary care settings, and we have had persons in the pediatric private sector in Trinidad and Tobago reaching out to us through the CMOH offices over the last week or two with rashes that have occurred and wondering if it is indeed monkeypox. So we have Dr. Sweet in particular and Dr. Edwards who will go into full detail training of our clinicians. I think today is just the kickoff, but we hope to have further sessions come in the coming weeks and months as the disease progresses across the world. And hopefully we can recognize it very early with a bit to treat and of course contain as the need be. So I will hand you back to Dr. Nimrod after saying those few words. And again, thank you very much to the T&TMA and all the presenters for coming together very quickly and doing this necessary and timely presentation.
Thank you very much, Dr. Parasram. So the honor is mine to actually introduce our first speaker this evening. So Dr. Jeffrey Edwards is chair of the Dermatological Society, and he's been no stranger to the Trinidad and Tobago Medical Association in terms of serving with us for dermatology national meetings. So we'd like to welcome you, Dr. Edwards. Thank you very much for taking time to put together the presentation, and we look forward to hearing your perspective and the overview on monkeypox. So over to you.
Thanks a lot, Dr. Nimrod, for that kind introduction. Thanks a lot to Dr. Parasram for inviting me. A number of slides here I got from my colleagues at CDC because I work in HIV. I work intimately with colleagues from CDC, so they passed on some of these slides to me. And I'm quite pleased also to see a number of persons attending from the Master of Public Health class. Remember, we have a Master of Public Health at UE, so any of you all young doctors willing to join, we're happy to have you all. So let's start our presentation. So in terms of the outline, I'll talk about the introduction, epidemiology, modes of transmission, clinical features, diagnosis, treatment, a bit about prevention and what clinicians need to know about monkeypox. So what is monkeypox? Monkeypox is a viral zoonotic disease primarily in the tropical rainforests of Central and West Africa, and is occasionally exported to other regions. The clinical presentation of monkeypox resembles that of smallpox, which is a related orthopox virus infection, but monkeypox is much milder. Mass vaccination of smallpox vaccine and then targeted vaccination and surveillance resulted in the elimination of smallpox in 1977. And then WHO confirmed the eradication of smallpox in 1980. And as a result of that, there was subsequent cessation of the smallpox vaccination. So the younger people have not received the smallpox vaccine. Monkeypox has emerged as the most important orthopox virus, which is an envelope double-stranded DNA virus. And this is thought due to the absence of vaccine-derived immunity from the smallpox vaccine. Monkeypox is less contagious than smallpox and causes a less severe illness. The natural reservoir of monkeypox is unknown. Animal hosts include a range of rodents and non-human primates, for example, monkeys. But some of the rodents include the rope squirrels, the tree squirrels, the Gambian pouch rat, and this seen in the example here, and the dormice. The orthopox genus also includes the variola virus, which is a smallpox virus, the vaccinia virus, which is a smallpox vaccine, and the cowpox virus. Monkeypox was first isolated in 1958 when it was observed there was a pox-like disease in monkeys kept for research in Copenhagen, Denmark laboratory. Hence the term monkeypox, because it first appeared in monkeys. In 1970, human monkeypox was identified in a 9-year-old boy in the Democratic Republic of the Congo. Two clades or subtypes of the virus exist. The West African subtype, which is less severe disease, and the Congo Basin clade or subtype, which is more pathogenic. Since 1970, human cases of monkeypox have been reported in 11 African countries, and they are noted here: Nigeria, had its first confirmed case in 1971, 2 cases, and then another one in 1978. And between September 2017 and December 2018, there were 316 reports from 26 states, 132 confirmed cases from 17 states, 7 deaths. The mean age was 29 years old. This was the largest outbreak at the time of West African. Remember, West African monkeypox is the less severe type, with continued consistent reported and confirmation of cases. So migration of monkeypox. In 2003, there was an outbreak of monkeypox in the US linked to shipment of wild animals for distribution in the pet trade. There were 47 confirmed and probable cases. However, there was no human-to-human transmission. There were 9 travel-associated cases from Nigeria between 2018 and May 2022, 5 cases in the UK, 1 case from Israel, 1 from Singapore in 2019, and 2 in the US in 2021. However, there were no flight contacts. No flight contacts develop infection, indicating that monkeypox is not very infectious. 1 healthcare worker in the UK developed monkeypox from one of the patients, and 2 family members acquired monkeypox from their patient family members. So how is monkeypox transmitted? Transmission occurs when a person comes into contact with a virus from an animal, human, or materials contaminated with the virus. The virus enters the body through broken skin, respiratory tract, or mucous membranes. Animal to human transmission may occur, for example, by bite or scratch, preparation or ingestion of wild meat, or direct contact with blood, body fluids, or lesion material, or indirect contact with lesion material, such as through contaminated bedding. Human-to-human transmission of monkeypox can also occur by direct or indirect contact with body fluids or lesion materials, contact with fomites, or exposure to respiratory secretions. So some of the examples of high and intermediate risk exposures include shared towels and bedding from patients, for example. Infectious bodily fluids and scabs may be present. Skin-to-skin contact with a patient who has monkeypox, and this is thought to be one of the most common methods of transmission. Being inside a room or within 6 feet of a patient during procedures that may create aerosols from oral secretions or skin lesions if you're not wearing an N95 mask or equivalent. However, there's good news. Monkeypox is not very easily transmitted. And my colleagues from CDC suggest that they don't expect monkeypox to become the next pandemic because, as I said, it was first described in 1970, and probably we'll ask Dr. Hines to speak about this. In terms of the incubation period, is usually between 6 and 13 days and may range from 5 to 21 days. The infection can be divided into 2 periods. The invasion period, which lasts 0 to 5 days, and this is characterized by fever, headache, lymphadenopathy. Now, lymphadenopathy is a distinct feature of monkeypox that distinguishes it from smallpox. There may be backache, myalgia, and fatigue. These are some of the systemic symptoms. And you can see here, lymphadenopathy in monkeypox here. You may see large nodes in the mandibular, cervical, or inguinal region in patients with monkeypox. Then there's a rash, which begins 1 to 3 days after the appearance of the fever. The rash tends to be concentrated on the face and extremities and on the trunk. And what I'm describing here is the typical monkeypox that was seen and described in Africa. We found nowadays that we are getting atypical presentations of monkeypox. So this is a classical presentation. It affects the face in 95% of cases, the palms of the hands and soles of the feet. Remember, not too many conditions affect the palms of the hands and soles of the feet. And if you're thinking palms and soles, we always think secondary syphilis, the great imitator. So palms of hands and soles of the feet in 75% of cases, oral mucous membranes in 70% of cases, genitalia, so it may present at STI clinics, and conjunctiva 20% as well as the cornea. There's a characteristic rash, starts off as a macule, which is flat, papule, slightly raised, vesicle, pustule crust with desquamation. And you get these deep-seated, firm, well-circumscribed lesions with central umbilication, and some may actually become confluent. These lesions tend to be of typically of similar size and at the same stage, so they tend to look alike. If you look at the photo below, you'll see that most of the lesions tend to look alike. They are the same, similar size and at the same stage. The rash is present on palms and soles, so again, may present at STI clinic, and pain and pruritus may be present. The patient is infectious once symptoms begins, so from the prodromal or rash until the lesion scab and the scabs fall off. And the number of lesions vary from a few to several thousands on a person. And here are some examples. You can see A here in a pigmented skin where you may see some papules and vesicles, and you can see here, let's see, D here, you can see a pustule. B and C, you can see these brownish macules on the palms and soles, and patient may present to STI clinic, and people may suspect secondary syphilis. You can see a subungual lesion in E. F, you can see F and G, you can see small papules, and G, you can see a small vesicle. And H, you can see an abscess being an ultrasound there. And you can see they're trying to drain the abscess via ultrasound-guided drainage. Again, vesicopustules on the dorsal aspect of the hand. Some have central umbilication, which is quite classic. And then you can see an umbilicated papule on the lower part of the leg. Again, more characteristic lesions. You can see a small vesicle. You can see pustules. You can see the ones on the palm aspect of the palm, some pustules and central umbilication. The lesions are the same shape and of the same stage. So those are the characteristic lesions of monkeypox. Remember, it can also affect the genital area. Satellite lesions, you can see 2 satellite lesions there. The blue arrow have also been described. So monkeypox is usually a self-limited disease in most patients, and most patients, get better within 2 to 4 weeks. However, in a few cases, severe cases may occur more commonly among children, so children tend to get more severe cases. And this is related to the extent of virus exposure, the patient health status, and the nature of complications. Underlying immune deficiency may be associated with worse outcomes. And it was found that vaccination against smallpox may offer some protection. However, remember, most people are vaccinated years and years ago, and immunity is thought to wane with time. So persons younger than 40 to 50 who have not been vaccinated may be more susceptible to monkeypox, as smallpox was eradicated in 1980, and there was a cessation of smallpox vaccination. So hence we have a more susceptible population. Complications, bronchopneumonia, dehydration may affect the GI tract, secondary infection, sepsis, ocular and corneal scarring, encephalitis. You may get skin scarring with pockmarks, and very rarely you can get death. The extent of asymptomatic infection is unknown, and the fatality rate is 1% for the West African variant, all right, and about 10% for the Congo Basin clade. In terms of diagnosis, people who collect samples should use appropriate PPE. Ideally, more than 1 lesion should be sampled, preferably from various locations on the body. One should vigorously swab or brush the lesion with 2 separate sterile dry polyester or Dacron swabs for preliminary and confirmatory testing. In the US, most of the labs can do the preliminary test. You can detect an orthopox virus, but for confirmatory testing, to detect there's actually monkeypox virus, they actually send the samples to the CDC. So you can break off the end of the applicator of each swab into a 1.5 0.5 or 2 mil screw tap tube with an O-ring, or place each entire swab in a separate plastic sterile container. It's advised that one shouldn't use or store the swabs in viral or universal transport media. Monkeypox is usually diagnosed by the PCR test, and as I said, CDC can usually diagnose it. So in terms of treatment, many individuals infected with monkeypox have a mild self-limiting disease, and in 2 to 4 weeks, they're better. So the prognosis depends on multiple factors, such as previous vaccination status, initial health status, and concurrent illnesses or comorbidities. Clinical care for monkeypox should be fully optimized to alleviate symptoms, manage complications, and prevent long-term sequelae. And secondary bacterial infection can be treated as indicated. So persons that be considered for treatment are persons with severe disease, encephalitis, hemorrhagic disease, and persons who may be at high risk for severe disease include those who are immunocompromised, the pediatric populations, particularly those younger than 8 years of age, pregnant or breastfeeding women, and those with 1 or more complications. In terms of treatment, the US has stockpiled a number of antivirals for the treatment of orthopox viruses. So people collaborate with the CDC if you have severe cases of treatment. There's antiviral called tecovirimat, all right, which was licensed by the EMA for the treatment of monkeypox, and cidofovir, and there's a vaccine immune globulin. As again, you have to collaborate with the CDC to get access to these. In terms of prevention, quick identification of exposures, contact tracing, and isolation of infected cases are key to limiting further spread. You need to educate your community, avoid contact with animals or fomites that may harbor the virus, training and reinforcement of good practice in healthcare, for example, hand hygiene and wearing of PPE. And then previous vaccination of smallpox was demonstrated through several observational studies to be cross-protective against monkeypox. However, as I say, the immunity wanes with time, and some persons who have actually got monkeypox have been vaccinated against smallpox. The previous smallpox vaccination may result in mild illnesses, and you can tell if somebody has smallpox vaccination by the scanned upper arm. In terms of other preventions, medical countermeasures stockpiled for the prevention of orthopox viruses in the US. There's a vaccine called Jynneos, which is an attenuated live vaccine, and this has been approved by the US FDA for the prevention of monkeypox in high-risk contacts. And there's a vaccine called ACAM 2000, which is a live replicating vaccine for active immunization against smallpox. This has actually replaced the older smallpox vaccine, and the US tends to give it to persons who are high risk of smallpox infection. In terms of a situation analysis, the CMO outlined a situation analysis as of June 1st, 500 cases in 30 countries. Here I had, as of May 26, 2022. And what is so different? The 2022 outbreak, what makes it so different? A large number of cases, all right, have been found in multiple countries outside of Africa. Some of these cases occurred in men who have sex with men, but not all the cases did. And monkeypox is not thought to be sexually transmitted. It's thought to be transmitted by close body contact. As a CMO mentioned, I think they had 2 raves in Belgium and Portugal. And as a result of that, there were cases of monkeypox from close body contact. They had cases in 2022 in persons who reported no travel history to countries where the virus is endemic. And in terms of the clinical presentation, it is a bit atypical. The rash is still characteristic, but it often starts in the genital and perianal area, and you may get a proctitis. and sometimes it doesn't disseminate to other parts of the body. So cases are being recognized at outpatient clinics, STI clinics, dermatology clinics, because they're easily confused with STIs because they present in the genital area. The prodromal symptoms may be mild or not occurring, and the reason for this unusual presentation is unknown at the present time. So what they did was they looked at some sequences of the virus from 13 specimens, and they found that these sequences were very similar to one another here. They're all consistent with the West African clade. Remember, the West African clade is the milder, results in milder disease, all right? And these sequences contain similarities to the 2018-2019 monkeypox cases in travelers from Nigeria. It doesn't seem to have mutated to a more easily transmissible form from the sequencing so far. So what clinicians should know about the diagnosis? CDC issued a health advisory on May 20th, 2022, advice for clinicians: be vigilant to the possibility of monkeypox if the characteristic rash is present. Note that the illness is presented atypically. Clinicians working in STI outpatient clinics, dermatology clinics may be the first to suspect monkeypox. Many patients have bile symptoms. It's easy to confuse with STI or varicella zoster, and Dr. Sweet will show you some of the differential diagnosis. Obtain a sexual history and a travel history from the patient to determine if any contacts have or had a similar rash. Obtain specimens for testing, notify the Ministry of Health, consider initiating contact tracing and monitoring. Dr. Hines will probably talk about that, and facilitate laboratory testing. In terms of treatment and prevention, what clinicians should know: all specimens reported outside of the endemic countries to the WHO were the West African clade of the monkeypox virus, which is associated with a milder illness, and no deaths have been reported as yet. So supportive care is typically enough. Antivirals are available through consultation with the CDC. Remember, I told you Tico, Viramat, and others. Contacts should monitor healthcare personnel who have been treating these cases of monkeypox. People should be monitored for 21 days. You can consider post-exposure prophylaxis with those 2 US licensed vaccines, which is a possibility to decrease, which is a possibility depending on the risk level. So if somebody came in contact with a case of monkeypox, you may consider that. And then pre-exposure prophylaxis for certain healthcare personnel are available. All right, so these are my references, and I want to thank you, and I'll pass you over to Dr. Nimrod.
Thank you very much, Dr. Edwards, for such a comprehensive review. What we are going to do, we're going to entertain a Q&A, question and answer session at the end of the presentations. And we will move ahead to Dr. Sweet, who's our next presenter. And after we finish with Dr. Hines, we will allow persons to actually send their questions in, and we will have our panel, our expert panel, give their responses. So the next person that we have the privilege of having with us is someone who is known, I say, as the godmother of dermatology in Trinidad and Tobago, our own Dr. Marilyn Sweet, very well known and qualified internationally and also in Trinidad and Tobago. She was definitely sought here for her expertise, and tonight she has the privilege to present to us the possible differential diagnoses that can present, so that you would have an idea of what to look for and how to elucidate what is monkeypox and what is not. So we would like to thank Dr. Edwards and welcome Dr. Marilyn Sweet to give her presentation.
Good evening, everyone. Can you hear me?
Yes, we can.
Okay, great. Sometimes I'm not too sure. I'm not very techy. All right, thank you so much for that wonderful introduction, Dr. Nimrod. It's a pleasure to be here. I'm honored to be asked to do this talk. After all, I tell people I'm in the twilight of my career. And what I'm going to share with you today is the differential diagnoses of monkeypox. I'm going to show you then some things that can look like it, that are not it. So am I sharing?
Yes, you are.
Okay, great. So my goal today mostly is to give you an overview of the clinical features of some blistering disorders. So note, I'm concentrating on the blisters because that is the classical presentation of monkeypox. And I hope to help participants identify at least some of the blistering disorders that they may be likely to see, even in the absence of monkeypox, and to help to distinguish between monkeypox and some other blistering disorders. I hope also to aid them in the decision about when to refer in order to facilitate rapid diagnosis and management. Just a few definitions: a papule, and you remember some of these from medical school. I hope you still remember them. A papule is an elevated palpable lesion less than 10 millimeters in diameter. A vesicle is also elevated, and this is what we term a blister, that is less than 10 millimeters in diameter and contains clear fluid. A bulla is a bit larger. It's greater than 10 millimeters in diameter and also tends to contain clear fluid. A pustule is also elevated, is a blister containing pus. An erosion is a superficial lesion created by loss of epidermis, usually from a blister. And an ulcer is deeper because it involves loss of epidermis and sometimes depth of dermis. I just want to say that locally, when an individual comes to me and talk about their skin blistering, usually they're describing the sort of situation where the skin has become dry and scaly and is red and irritable. They're not always describing fluid-filled blisters, but for us as dermatologists, a blister contains fluid, and it's usually a vesicle or a bulla. You will see this evening some localized blisters. You will see conditions that start localized and have a potential to become generalized, and then you will see conditions that are generalized or extensive from the word go. And I'm not going to refer at all to blisters due to trauma, for example, burns. We'll start with impetigo. This condition occurs mainly in children, and in most cases it is due to Staphylococcus aureus, but also strep pyogenes, and sometimes they may be both. The impetigo may be bullous or non-bullous, and bullous impetigo we recognize is due to the local production of an exotoxin by Staph aureus. So this allows the skin to split and the fluid collects. This can spread quite rapidly, so it's not unusual for a child to have impetigo and all of his siblings, even the parents, get lesions. And this can be accompanied by fever, malaise, and lymphadenopathy. Sometimes it may resolve without treatment, but typically they tend to need a topical antibiotic or a systemic antibiotic if the condition is extensive. But this is usually a clinical diagnosis. However, swabs may be taken for culture and sensitivity. Do know that it's important to manage it early because patients can go on to develop Staphylococcus scalded skin syndrome and even post-streptococcal glomerulonephritis. So here's a typical case of bullous impetigo, and you see that there's a large circular lesion there on the proximal aspect of the knee that was a large blister. It widened. The center has now become quite dried with a scab, but you can still see blisters on the edge. And inferior to this, there on the knee, there are 2 vesicles, and they are cloudy and containing pus. We now move on to a bullous fixed drug eruption. I think that this is one diagnosis that tricks a lot of non-dermatologists because the patient appears suddenly with these dark spots and they don't know what to make of it. The first attack of fixed drug eruption tends to occur within days to 2 weeks, roughly 2 weeks after exposure to a particular drug. But in subsequent attacks, it may occur as early as a few hours. The reason it's called fixed is because it tends to recur at the same sites each time that the drug is taken. And additional sites tend to be recruited with recurrent attacks. The typical location is the lips, the extremities, and often the genitals as well. The classical lesion is well demarcated. It's a round erythematous plaque, usually with a darker center and a halo of erythema. It tends to be quite itchy, and a central bulla may form, hence the term bullous fixed drug eruption. But I think the majority of cases tend to be just the erythematous plaque that eventually becomes darker with time. It leaves a discrete, hyperpigmented, fixed, dark macule. These can, however, become generalized. So there's your classical lesion on the left with the dark center and the erythematous edge. There are two of them there, actually. And every time the patient takes the offending drug, this will become active again. You can see that there are many more lesions on the anterior trunk of this other patient on the right, but the same sort of characteristics with the dark center and the erythematous edge. A lesion on the lip, there's one here at the angle of the mouth, and then there's a fairly large one here on the chin. And you can imagine this patient getting a diagnosis of something like herpes simplex, simply because there is a blister on the lip, or fixed drug eruption on the lip. Here is a bullous lesion, and you can see again the demarcation, the erythema at the edge, but there is that bulla in the center. So this is classical bullous fixed drug eruption. So if this patient had extensive lesions, this may be a difficult diagnosis. The history is very important because the offending drug is often forgotten. For example, a female who may take a non-steroidal anti-inflammatory drug only at the time of dysmenorrhea. When you ask, are you on any medication? She says no, but really she's not on continuous medication, but she takes this intermittently for dysmenorrhea. So apart from non-steroidals, the sulfonamides, often the patients who like to take things like cotrimoxazole for sore throat, and then of course the anticonvulsants may also be provoking drugs. We do know of a fixed food eruption because there are some foods that may induce a similar response. We move on to bullous insect bites. Your classical insect bite, what we know as papular urticaria, is usually an erythematous papule in response to being bitten by an insect. And this is usually an itchy bump, which may later develop into a tense, clear blister. Of course, it becomes excoriated because it's so itchy, and secondary infection may follow. And when it heals, it leaves post-inflammatory hyperpigmentation. These tend to occur mostly on the exposed parts of the skin. You will not find them like on palms and soles. It's typically the outer aspects of the arms and legs. And any insect can do it, any biting insect, mosquitoes, sandflies, ants, and wasps. This is a typical appearance of papular urticaria here on the legs. You can see some recently active excoriated papules there on the shins, and a lot of post-inflammatory hyperpigmentation and scarring. We see quite a bit of this here in Trinidad because of mosquitoes. This is a bullous reaction to an ant bite. And there's a large shiny blister with clear fluid, and there is some surrounding erythema. We move on to herpes simplex. We do know of herpes simplex in relation to the common cold sore, but do note now that, you know, you can get type 1 and type 2 occurring at any location. So what we used to be taught about type 1 occurring around the mouth, above the waist, and type 2 occurring below the waist, know that that no longer applies. Sometimes the viruses are there and there are absolutely no symptoms. But typically, the appearance of blisters is preceded by itching, burning, or pain. And then within a couple of days, you find grouped vesicles on an erythematous base. They generally contain clear fluid. However, they may become pustular with time. They tend to be restricted to one anatomical area, which is non-dermatomal compared to, say, herpes zoster, which is a different virus. Any location is possible: the lips, the mouth, the genital area, the sacrum, the buttocks. These are typical locations, but you can get it on the finger where it's called a herpetic whitlow. You can get it on the back of the thigh. You can get it any location. So here is your classical herpes simplex on the mouth, what we commonly call the cold sore. And this is a fairly common presentation. I suspect a lot of people in our group have probably had this sort of thing after they've had a high fever or viral illness, or they've spent a long time in the sun or in cold weather. And this slide, which I borrowed from Dr. Edwards, shows vesicles here on the penis. And it's important to take note of this one because Dr. Edwards mentioned to us that there have been atypical presentations of monkeypox, and therefore you should have an index of suspicion for lesions appearing in this location. But obviously the situation will help you to decide, the clinical situation will help you to decide which direction to go in with this one. Primary infections with herpes simplex tend to be accompanied by fever, malaise, and regional lymphadenopathy. But you've heard from Dr. Edwards that lymphadenopathy is a significant feature of monkeypox disease, but one would expect with the primary infection of herpes simplex, since it tends to be in one anatomical location, that you wouldn't expect to get generalized lymphadenopathy. You will get lymphadenopathy related to the location of the lesion. Acute stomatitis is a feature of primary infection in infants and children. Of course, these vesicles break down and they may cause painful erosions and even ulceration in immunocompromised patients. The vesicles may be widespread in immunocompromised patients and patients with atopic eczema. And I'm sure the pediatricians have seen this from time to time. Eczema herpeticum. Every single vesicle here is due to herpes simplex. And this is in a child with atopic eczema. And the lesions were not just on the face, you can see coming down on the neck, and there were vesicles on the rest of the body as well. But these tiny clear vesicles, and this is eczema herpeticum or extensive herpes simplex in an atopic child. We move on to herpes zoster, which is shingles, reactivation of the varicella zoster virus, the virus that causes chickenpox. This condition tends to be unilateral and dermatomal in distribution. However, you may have multiple dermatomes involved, usually contiguous dermatomes. Pain is believed to be a preceding symptom. However, there are many patients who experience no pain before the lesions appear. One may also get itching and burning. The vesicles are grouped on an erythematous base. They do tend to have a slightly grayish quality about them. They may become erosions after a while and become crusted with scabs. Secondary infection may occur and scarring is frequent. Dissemination is not usual. It tends to remain restricted to the dermatome, but in an immunocompromised patient, it may spread. So here is classical herpes zoster or shingles on the trunk. You see here, and this involved more than one dermatome. And there's that erythematous base, and there are the vesicles. And over here, I think you can appreciate this sort of shiny, silvery gray kind of appearance. Some of them have already started to dry up, but again, the erythema on the base there. This is disseminated zoster. And Dr. Edwards mentioned that the bully of monkeypox are sometimes umbilicated. Well, here is umbilication in the vesicles here of zoster. There is the umbilication. This is evidence that the patient started off with a typical dermatomal zoster, and you can see that coming down the middle there. Doesn't really cross midline, and he's already crusting here. But this patient was immunocompromised due to a malignancy, a hematologic malignancy, and developed disseminated zoster. Blisters of the hands and feet, Pompholix. Some of you may remember that again from medical school. You say use chiropompholix for when it occurred on the hands and podopompholix for when it occurred on feet. Also called dyshydrotic eczema. It's a pruritic type of eruption. Sometimes the vesicles are quite small and they're under the skin there. You can feel them. And you can see them looking like sago grains. I hope sago is familiar to most people here. But I guess in the day and age of Cheerios and so on, nobody knows about sago. But a history of atopy may be present, and the individual may have eczema elsewhere. So this is Pompholix or dyshydrotic eczema. So here are the hands with the vesicles there along the side of the fingers. And lots of these people, this is an adult, but kids will say, the parents will say every time they have a test is when this flares up, and you get them at the sides of the fingers, and in this one, some eczema on the dorsum of the hands as well. But there are the vesicles in the palms, there on the thenar eminence as well. So this is Pompholix. We move on to hand, foot, and mouth disease. So I think that we're starting to see some hand, foot, and mouth disease in the public clinics now. Dr. Pasram mentioned this is due to Coxsackie A16 or Coxsackie A6 or enterovirus 71. It's usually a childhood illness, but we do see it in some adults. It is spread by droplets, but also by fecal-oral transmission. So the hand washing would be very important in this case. Fever and malaise may precede the rash. You would see at first erythematous macules, then vesicles, and they would be itching. The child would be itching. Palms and soles are often affected as a classical area, so you can understand why this may be confused with monkeypox and vice versa. The dorsum of the hands may be involved, but children often have lesions on the buttocks, on the genitals and perineal area, and they may have involvement of the mouth with a painful stomatitis. It does tend to spare the trunk, hence the name hand, foot, and mouth disease. So here is hand, foot, and mouth, perioral lesions. I'm not very good at photography, so I was not able to demonstrate the ones inside the mouth, but you can see there are a few there on the neck, but notice that the trunk there is spared. and there are vesicles on the butt and vesicles and erythematous macules on the soles. And that is your typical hand, foot, and mouth disease in a child. And here it is in an adult female, and she has the erythematous macules there and vesicles on her fingers and vesicles there on the sides of the feet. In this case, I suppose you might have said, oh, well, it looks like Pompholyx, but generally the history, you would get the history of the fever and the malaise and then the appearance of the rash, and then you know what you're dealing with. So let's go to chickenpox. Now, we do know that chickenpox is what gives you shingles. So it's the same varicella zoster virus. It is spread by droplets or direct contact with lesions. So we know this is a contagious viral illness. Usually there's a prodrome of fever and malaise. Typically the rash starts on the face and the trunk, and then the extremities become involved. So this is a centrifugal spread from the trunk and face and moving outwards. Initially macules, papules, and then obvious vesicles, which become crusted and scabbed and leave the telltale scars in many patients. It's very itchy. Again, there may be that umbilication. The classical thing about chickenpox or varicella zoster is that the lesions when the patient presents are often in different stages of evolution. So you will see intact vesicles, you will see excoriated papules, you will see crusting. They're in different stages of development. And lymphadenopathy is usually present, but I suspect, not having seen a case of monkeypox, I suspect that the lymphadenopathy will never approach the kind of massive lymphadenopathy that tends to be characteristic of monkeypox. So here is chickenpox on the trunk, and you can see the extensive involvement. Then they're scattered all about. And here again, and some of them are already umbilicated. There they are. This has formed a pustule there. Here's an intact vesicles there. And there is the central umbilication. But note, it is not that nice, neat, tense pustule or even bulla, sorry, that you get with monkeypox. It's a different kind of presentation. We move on now to some generalized blisters. Erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis. Some of these names are familiar to you. Staph-Scalded syndrome. And I'm going to move a little quicker now. Erythema multiforme may be caused by a number of conditions, but it's believed to be mostly due to herpes simplex. So it's a kind of like a secondary response to herpes simplex, but it can be caused by other organisms as well as autoimmune diseases, including systemic lupus and some drugs. It tends to start on the hands and feet and then spread to the trunk. Typically macules, papules, and then the iris or target lesions, which are due to that sort of concentric circle where the concentric circles, the center is darker, but a central blister may form. Patient may have involvement of the mouth and the eyes, and recurrences are possible. And there is the lesion with the central darkening. There are the erythematous macules on the palms. And there is so-called, in this case, more sort of iris rather than target, because you actually only have two circles, dark and then the lighter red. We don't have multiple concentric circles here. Then the Stevens-Johnson syndrome, toxic epidermal necrolysis spectrum, same spectrum of disease, just depends on how much body surface area is involved by the blistering. Less than 10%, Stevens-Johnson's 10 to 30% overlap, and greater than 30% becomes TEN or toxic epidermal necrolysis. This one is more likely to be due to drugs, and these are the common agents: nonsteroidals, sulfonamides, anticonvulsants. Infections may do it. I'm sure Dr. Edwards has seen it with the antiretrovirals. There is believed to be a genetic predisposition, and there are now tests that are available so you can test before you put a patient on carbamazepine. I don't think that test is available here, but it is a standard of care in places like the USA, where they would do the test before they start carbamazepine. Patient usually has fever, malaise, upper respiratory tract symptoms, and they do have atypical targets that are not as discrete as what you see with erythema multiforme. And then the skin starts to separate. It separates on gentle pressure. When the blisters are present, they are flaccid blisters, so therefore not to be confused with monkeypox. And it can be quite widespread, and there's increasing morbidity and mortality as it becomes widespread, and there's systemic involvement, especially in adults. And this is toxic epidermal necrolysis. You can see this dusky sort of erythema, and it has become confluent in some areas. There's involvement here of the lips, buccal mucosa, and there's that loss of epidermis, as though she was burnt. So they often are managed by burns units. The staff called scalded syndrome. The pediatricians are familiar with this, mainly in children less than 5 years old, but occasionally adults, and due to the exfoliative toxin produced by Staph aureus. Usually the patient has had an infection somewhere else, localized infection like impetigo affecting the skin, conjunctivitis, surgical wounds, and in neonates, the umbilical stump. The skin then starts to get red and tender, and this is distant from the infection site. Flaccid blisters develop, they rupture quickly, producing shiny, moist areas, and that's why it's called a scalded skin syndrome. And the skin also separates on slight pressure like TEN. It's called a Nikolsky's sign. So these pictures, which I borrowed from DermNet, you can see their flaccid blister there, but here these have already separated, and there is a scalded skin syndrome, as though you threw hot water on the individual. It often progresses, it usually progresses rapidly, so it's important to recognize it. Note that the organism is not found in the affected skin. It will be found in the primary infected lesion, but it usually heals quickly without scarring, and thankfully the mortality is low in children. The immunobullous disorders, I've chosen 3 of them in the interest of time. Bullous pemphigoid being the most common, is seen mostly in the older age group, older than 70 years, but it can occur in the younger. Pemphigus can occur at any age. Linear IgA bullous dermatosis occurs in adults of any age. It occurs in children, and it used to be called then chronic bullous dermatosis of childhood. Oops. Bullous pemphigoid may present months before the blister with urticarial-looking rash, eczematous-looking rash, but when the blisters are present, they are tense, clear vesicles, and bully, often large and sometimes hemorrhagic-looking. So the fluid in is usually clear, but sometimes looks bloody. In pemphigus, the blisters are flaccid blisters, starting off clear and eventually becoming pus-filled. In linear IgA dermatosis, they tend to form an annular configuration. In bullous pemphigoid, the location is on the abdomen, the flexural areas, and especially areas like the upper thighs. The palms and soles may be affected, so it's important to note that if you're trying to distinguish from monkeypox. In pemphigus, the mouth is often involved first, long before the other areas become involved. And in the linear IgA dermatosis, the trunk, the extensor aspect of the limbs and the buttocks, as well as the perineal area. They all cause itching, but in pemphigus, because the blisters break so quickly, the skin is often quite painful. The difference is in the level of the split, hence the clinical presentation. Bullous pemphigoid gives you a tense, clear blister, and this is because the split is subepithelial. It is just below the epidermis. In pemphigus, the split is within the epidermis, so you get a flaccid blister. In linear IgA, it is also subepithelial, like pemphigoid, and the two therefore can be confused clinically. Immunofluorescence is what shows everything up to us as a dermatologist. If we can get this done, then we find deposition of immunoglobulin G and or complement 3 at the basement membrane zone for bullous pemphigoid, and you get IgG or C3 in the intercellular zones in pemphigus vulgaris. IgA is what would be found at the basement membrane zone in linear IgA bullous dermatosis. And just to quickly show you some clinical pictures, this is before the blisters appear, and this sort of presentation can be there for weeks and even months before the diagnosis is made, because we often don't make the diagnosis until the blisters form. So the tense, clear blisters, some have already broken down to form an erosion, but they may last for several days before they break. Some may be hemorrhagic with blood-stained fluid inside. This is pemphigus vulgaris with flaccid blisters. Sometimes they become pustular, and when they break quickly and they form erosions. They leave post-inflammatory hyperpigmentation without scarring. This patient, his blister broke down and he's got a lot of crusting here on the cheek. This actually took quite some time to heal. The linear IgA bullous dermatosis, which is fairly uncommon, but you can see these huge, tense blisters. In this case, they are hemorrhagic, extensor in distribution, which is typical for this particular condition in childhood. Some of them forming the annular lesions, not so easy to see, but there they are, where the blisters are on the periphery, as opposed to this where you get a whole intact blister. There are other blistering conditions which you should be aware of. You may not see it, but again, because this one here located on the extremities could be a differential for monkeypox, but these are tense, clear blisters. Note, of course, the absence of that red areola that you saw with monkeypox. And these are just getting larger and larger with time. They're not as nice and neat with that areola like monkeypox. But this is a type of pemphigoid occurring in pregnancy, and it's again a subepithelial blister. So in summary, I've tried to present to you a number of blistering conditions that will present with vesicles or bully, because that is the typical presentation of monkeypox. The history is always of utmost importance. You must find out about drugs, whether there's any focus of infection, whether a patient has traveled, but you heard that some patients have absolutely no history of travel, whether there may be underlying illness, as may happen in the patients with disseminated zoster and eczema herpeticum. Ask yourself, what is the likelihood of the rash being monkeypox, given that even at this time, it is still in limited places, and the human-to-human transmission, as we heard, is low. You want to hear about the evolution of the rash. Was it sudden in onset, all of it coming at one time? Was it sort of gradual in onset, as would happen with conditions like pemphigus and pemphigoid? Was it associated with pruritus or pain? Was lymphadenopathy present? You saw that the viral rashes like hand, foot, and mouth, chickenpox, they're all going to give lymphadenopathy, but with monkeypox, there's massive lymphadenopathy. Are they accompanying systemic symptoms? The viral rashes tend to have fever and malaise as prodromes, but in the monkeypox, they have that significant myalgia as well and backache. Keep in mind that there's some localized blistering disorders that have the potential to become generalized. We have some similarities between the rashes, especially the viral ones like chickenpox and hand, foot, and mouth disease. But remember to refer patients with generalized blisters to a dermatologist if you think you're out of your depth. Thank you.
Okay, thank you very, very much.
Sorry, I was a little bit long with that one.
No, you took us all the way back to med school and couldn't have been, more extensive and thorough. I'm totally impressed as well. So thank you very much. I think you've covered from A to Z in that presentation. So again, excellent for both presenters. And then our last presenter who's joining us, since we're trying to get everybody else out and on time, is going to be Dr. Avery Hines. So Dr. Avery Hines is, and let me just summarize very nicely, is epidemiologist at the Ministry of Health. All right, he's currently the technical director of the epidemiology division at the Ministry of Health in Trinidad and Tobago. Completed his MBBS at UWI. He had his master's in the UK, University of Cambridge. He has a postgrad in emergency medicine, and he served as a national medical epidemiologist at NWRHA. And I could say almost across most of the sectors that I've known him from med school to date. And we have the pleasure of having him present with respect to the epidemiological review in terms of surveillance and reporting for monkeypox. So we'd like to invite Dr. Avery Hines to join us. He's also part of the T&TMA family as well. So with that being said, welcome to the platform, Dr. Hines, and we await your presentation.
Okay, can you hear me? Am I audible?
Absolutely
yes.
audible.
Okay, great. Okay, so thank you, Dr. Nimrod. Thank you, Dr. Edwards. Thank you, Dr. Sweet. I'm going to be relatively brief because I actually have, I'm going to join the line for questions afterwards to ask Dr. Edwards and Dr. Sweet a couple of questions in terms of trying to get us to focus on how to distinguish between all the things that this could be and monkeypox itself. In the interim, I'm going to share my screen, and I'm going to put up what is really a working document, and the interim surveillance guidelines for monkeypox surveillance at this point in time. So I'm stressing interim because this can change, will change. And once I get the slides to change, I'll be in a good place. And there's a little bit of sticking going on here, but the definitions themselves will be updated as the public health situation changes. So while the PowerPoint presentation itself gives a little bit of technical difficulty, I will start talking when I try to get it to actually fix itself. So what we're looking at is the fact that we're going to have several people turning up with several different kinds of rash presentations. And we really want to be able to make some sort of distinction between the actual diagnosis that we're looking for, which is monkeypox, and all of the other differentials. And what the WHO has done so far is they've given us some working suspected case definitions that I think have also been passed down to CARPHA. CARPHA has been utilizing them as well. Okay. Did you see that? Did anyone else see that? I just saw the entire presentation presented itself. Thank you, PowerPoint. Let's try this again. Good. So can we see the first screen now? It just says interim surveillance guidelines. Yes?
Yes, yes.
Okay, good. Okay, so what we're using are the current case definitions the WHO would have provided, and those case definitions were as at the 20th of May, 2022, will be updated as necessary. And we are looking at trying to make some sense of the historical bit, the bit that Dr. Sweet spoke about when she said, well, the history is always most important, and what sorts of information makes us think, okay, this is monkeypox as opposed to something else. So a person of any age presenting in a non-endemic country for monkeypox with an unexplained acute rash and one or more of the other symptoms below since the 15th of March, 2022, when they believe that this particular outbreak, that's the outer limit for the new cases showing up for this particular outbreak. Before that might have been something else. From the 15th of March come forward, anybody who has the unexplained acute rash plus the headache, acute onset of fever, muscle pain, back pain, generalized weakness, and the lymphadenopathy that Dr. Sweet and Dr. Edwards spoke about. In addition to which, we have managed to eliminate some of the other causes of acute rash, like varicella zoster, herpes zoster, measles, very important, because we are a region that has eliminated the transmission of measles. We have to keep looking for testing, for checking for that as well. So we do want to keep that in mind as a differential. That not that we think it's actually in circulation, but one of the things to exclude, and possibly one of the things periodically to test for, although the testing is going to be different. I'll come back to that in a moment. So other bacterial skin infections, disseminated gonococcus infection, primary or secondary syphilis, all of the things that we've basically gone through in the last two presentations. We want to have, to some extent, ruled some of those out. And I believe here is where we do also want to, and I'll let CMO comment on this, have some sort of initial screen, some sort of initial check between the primary care physicians and dermatologists in the various RHAs, just for reference, just to eliminate or screen out some of the obviously not monkeypox types of diagnoses, while we still keep a moderate index of suspicion so that we don't miss things. So we are going to, maybe at the end of this, at the plenary, have a conversation about how we can possibly arrange that sort of informal consultation network to reduce the excessive and unnecessary referrals for monkeypox testing, but at the same time not miss things. So getting the help of the dermatologists to allow us to accomplish that. Now, with all of those things in mind, a probable case is then somebody who meets those definitions and has some sort of link that makes us think, yes, this actually could be monkeypox. An epidemiologic link, whether it's face-to-face exposure to someone who is a confirmed case, and this includes healthcare workers, but also family members or individuals in the same school, etc., but to a confirmed case. So an epidemiologic link to a confirmed case, direct physical contact with skin or skin lesions, according to the mode of transmission, and this includes sexual contact, and although sexual contact doesn't mean that it's sexually transmitted, but the proximity that's usually required for sexual contact then allows that to be part of the list of contacts that we would want to ask about when we're trying to determine whether someone has had a relevant exposure to a confirmed case or not. And then contact with contaminated materials, clothing, bedding, utensils. So again, within families, someone who's taking care of an ill individual and has contact with these materials, their clothes, their bed sheets, etc., without any sort of protection, that would be another high risk sort of contact with a confirmed case. And it has to be within 21 days before symptom onset, because the duration, the maximum duration of the incubation period is 21 days. Also, of course, reported history of travel to a monkeypox endemic area. Although we've been saying that most of the, or many of these cases have not had that, you won't leave it out of the questioning. So yes, reported history of travel to a monkeypox endemic country in the 21 days prior to symptom onset, and those who may have had multiple sexual partners in the 21 days before symptom onset. And this is really because of the network throughout which we are seeing these cases having shown up in the UK, in Europe. We're seeing where there seems to have been some sort of possible point source exposure, some mass gathering among individuals within some of these MSM networks, and that's where a lot of the cases then showed up. And we actually have to give credit to the individuals in these networks who have a sort of early health seeking behavior when there's any sort of genital rash or anything along those lines, because their early presentation and disclosure then allowed this to be picked up. So that health seeking behavior that has been encouraged over the last 4 decades with HIV and other STIs, and trying to get people to present early, not harbor symptoms. This is paying off some dividends in terms of actually getting people presenting when and as they come up with an unusual rash in the genital area. So it's something to keep in mind as we see patients, if they have that sort of presentation as well. We'd want to keep that in the back of our minds. A confirmed case would then be a case that meets the definition in terms of description, meets the definition in terms of probable or possible exposure, and then goes on to have a laboratory confirmation. That laboratory confirmation being something that is done usually by PCR, and we'll go through that in a little more detail. So if a case meets the suspect case definition, meets the probable definition because of exposure, we want to know what we're going to do. How do we report? To whom do we report? What samples do we take? What do we do next? And when we're looking at these reports, we will develop both a specialized case report form and a database to capture all of the information, but we expect that we won't be seeing a large number of genuine cases in this time frame. So we're still working on those things. So the elements of these forms and databases will be at the minimum things like this: date of report, the reporting location, the demographics of the case, when symptoms first started, when did the fever start, when did the rash start, whether there's a travel history or not, whether there's an exposure to a probable or confirmed case or not in that 21-day period, and relationship and nature of contact. So a little detail would need to be elicited in terms of nature of contact. So just sat in room next to a case doesn't really constitute that kind of exposure. But if you're a healthcare worker providing care, doing something that generates an aerosol, making physical contact, then yes. Recent history of the multiple partners, as we said, because of that whole MSM network presentation that we saw with this particular global epidemic. The occupation, whether the person's a healthcare worker or otherwise, the vaccination status, although for most of the people that we expect to see, that smallpox vaccination status would tend to be nil. Presence of a rash, number and location of lesions, other clinical signs or symptoms, as per the case definition, and the date when the specimen was collected. Now, here's another point that I'm going to actually allow the CMO to weigh in on. A lot of this information actually is already included in what we have as our measles case investigation form. So we can utilize that as a stopgap, but the problem tends to be if we utilize that form, it tends to trigger at the laboratory and at the CARFA level the query of why aren't we taking the measles sample? But it does, in fact, the sample, the case form does in fact give you the option to highlight other rash as opposed to query measles as your, or other rash illness as your differential diagnosis. So I will get some clarity from the CMO, and maybe can weigh in at the end of this on whether we want to use that as an initial or whether we want to do an entire de novo form, but this is rapidly evolving. The laboratory testing, this is taken straight from CARPHA's last update release. And we're saying that we can use molecular methods for this, that is the PCR methods, etc. It is recommended that you inactivate samples. This is for the laboratory. This is not for the clinicians. At a BSL-3 containment level, and then you can manipulate them in a BSL-2 level laboratory. And swab of the lesions. Now, they did say in transport media in the CARPHA document, but again, this is rapidly evolving, so this may change. Or if there is no transport media, then we can just send the swabs dry, but it should not be cotton swabs. It would need to be the Dacron swabs or the other material, the nylon, as Dr. Edwards had mentioned earlier. All right, now you swab, particularly when the lesions are dry, you need to swab that area vigorously. The roof of the lesion, that top of the skin, can also be sent. So there's a few different things that we can take and send for the laboratory confirmation. And as I believe both Dr. Edwards and Dr. Sweet said, you want to take samples from the lesions at different points of the body, given that they'll be in different stages of evolution, so to speak. One of the polyester swabs on that thin plastic wood or aluminum shaft, not the cotton swabs, should be used. Additional specimens accepted, lesion crusts, tissue biopsy, least preferred. And then storage. After collection, the swabs can be stored in 2 ml tubes after breaking the shaft or other sterile containers. They recommend you don't store multiple swabs in one container. And you can store the swabs at just general refrigeration, 2 to 8 degrees Celsius, if shipped within 24 hours of collection. If it's going to be longer than that, they suggest that we swab or we store at -20. So again, this is for the laboratory, because that's their, that storage is then their responsibility once they've received the sample from us. What we would need to do as clinicians is ensure that the sample we take gets to our local public health lab within 24 hours. The reporting pathway. Once we've done this, we need to do a couple important things. We need to send the case investigation forms to the CMOH office, that's the County Medical Officer of Health office, for them to send on to the Epi Division. And these officers can either scan, take a picture of, or email the initial case investigation forms directly to me, and we'll work out the receipt within that database that we're developing as that tool evolves. We also need to have some notification that a sample has been sent, so we can alert the lab, because it needs to be a conversation between our local lab and the reference lab in terms of what to do with the sample. So immediate telephone notification via WhatsApp should accompany transmission of the form, so we know, okay, we got something, look for it. And as we said, the electronic database will supersede the forms by the end of next week. So we should have something a little more robust and stable to capture the info in by the end of not this week, but the week to come. And the public health measures with respect to what you do with the patient and their contacts. The first thing, the contact tracing. We do want to ensure that we have identified all the individuals with whom they've been in close contact in the previous 21 days to see where they may have contracted their monkeypox or their illness, whatever it is, from, and also those with whom they would have been in contact since they became symptomatic. So you're tracing in 2 directions. And we're really just going to monitor the individuals with whom they came into contact subsequent to becoming symptomatic without quarantining them. But we do want to monitor them on a daily basis, looking for fever, looking for that prodrome, so that if they start to become ill, then you can ask them to come out of circulation. But quarantine isn't immediately necessary just because you're a contact. And then, of course, for those who are infected, who are having symptoms and a rash, we would want to have them isolated until all the lesions have resolved fully, until they've dried up, scabs have fallen off, etc. So this is really just in a nutshell, very quickly, the direction in which these reporting pathways will all be flowing, and what we'll be collecting and what we'll be sampling. So I try to make it as short as possible because I want to save a lot of time for us to talk a little more about distinguishing between what we're talking about here and the list of differentials in a more meaningful and more practical way, and also was setting up that sort of potential referral or review level prior to identifying something the suspect case. So I am going to actually bring my talk to a close, turn you back over to Dr. Nimrod, and then we'll have hopefully a fruitful conversation.
Okay, thank you very much, Dr. Hines, for the epidemiological public health perspective with respect to cases and the case definitions. We've had an excellent lineup, a panel of speakers this evening. Thank you very much, Dr. Parasram, for your recommendations, and this has been very enlightening. And we still have a full complement. We had 100 people logged on all the way through. So that being said, we'd like to open the floor for questions for any one of the panelists. Could you post your questions in the chat, and we'd be quite happy. And if you'd like to identify the person that you're addressing your question to, then we'd be happy to do such. I think if I scroll up a little bit earlier, I think there were, at least 2 questions. And I think the first question, if it wasn't already clarified, for Dr. Ramsawak Lala, asked if does chickenpox offer any protection in terms of the varicella vaccine? Would anyone care to just reiterate, for those who probably came in a little later, if there was any clarification with respect to her question?
I can probably take this.
Thank you.
Chickenpox is a herpes virus. The monkeypox is a orthopox virus, so 2 different viruses. So the herpes virus wouldn't offer any protection against the orthopox virus. Smallpox and the vaccine near the smallpox vaccines are orthopox viruses. So vaccination against smallpox will offer some protection, as I say, but it wanes, and most people 40 to 50 would not have been vaccinated because smallpox was eradicated in 1980.
Okay.
Just to add to that, I know that the figure that they gave for the levels of protection with the smallpox vaccine was somewhere around 85%. But again, I'm not sure that that 85% applies to someone who was vaccinated 40 years ago. So it may be 85 or less. But that was sort of the range that they've given in the initial documentation on vaccine protection.
Okay, great. Thank you very much for both your responses. Okay, so Dr. Halai, good evening, is asking what PPE or personal protective equipment is required for swabbing? And if swabs are unavailable, where can we refer patients to be swabbed or for swabbing?
Okay, so I think I'll take that one
Sure.
to start, and then I will allow both Dr. Sweet and Dr. Edwards to add in terms of additional PPE, but the sort of basic barrier, the normal infection prevention and control mechanisms that we would use for anything that is a contact, something spread by contact, or something spread by large droplets, which is the other potential mode of transmission, would be the PPE. So you'd need to have gloves, it would be recommended that we wear a mask, it would be recommended that we have the disposable gauntlet, etc. So it's not going to be anything that requires a full spacesuit, for example, but definitely mask, glove, and gowns would be sort of that basic trio that we'd want to have at the initial instance. If it is that a swab is not available, then again, contacting the CMOH office to identify the case, and then allowing the CMOH office to follow up in terms of getting a swab, following up on the surveillance aspect of things would be the recommended next step. So for those who aren't familiar with the CMOs, it's just as an opportunity to sort of strengthen that connection, that network between our primary care physicians, both public and private, and the CMOHs, because that's where we want to concentrate a lot of the the public health aspect of the response. Again, if the CMO is on and he wants to make an intervention and provide additional or different guidance, then by all means, he is more than welcome to do so.
Thanks. Yeah, so the only thing I would add to it is when you're actually taking this swab, you'll probably want to have some sort of eye protection as well, just to prevent any sort of splashing that may occur. So in addition to the normal barriers, thankfully, COVID-19 has really taught us as clinicians how to be very cautious, and all the measures that we have taken for dealing with COVID-19 apply. So as Dr. Hines would have said, gloves, you can wear the disposable gowns. In addition to that, you wear a mask. To be extra cautious, of course, you could use an N95 mask. And in addition to that, wear either goggles or shield as your best protection at this point in time. It is not a pathogen that has been shown, at least in the past, to go beyond that. And you would have seen in Dr. Edwards' presentation, for example, when they did the analysis and the sequencing of this particular virus that is spreading from West Africa, you're seeing no significant mutations, which, of course, early on in the pandemic, there was a concern that it was a mutated virus, especially seeing what had happened so far with COVID-19. But it being a DNA-based virus, the mutation rate is usually lower than you would see with diseases like viruses like COVID-19. So again, yeah, similar to what Dr. Hines was just adding on a bit of extra protection in terms of shield or goggles, as the case may be. The linkage with the CMOH, again, is to reestablish, and their numbers and emails are on the Ministry of Health's website for those that don't have it, so that they can be contacted. The National Public Health Lab, Trinidad and Tobago National Public Health Lab, again, is a source for information. And of course, you all will have linkages with them through the CMOH and even through the health centers to actually get swabs as well as tubes or other material that is required for the swabbing to take place. I will touch base with the director again to ensure that we have everything at least out throughout the system so that there can be easy access. And hopefully by tomorrow that can be completed to make sure that we do have availability of swabs at all the sites and availability of the containers to house them in. In the absence of the screw top, I think we can safely use a red top in the first instance. Once it doesn't contain any UTMs, we should be okay for taking the sample.
Okay, perfect. Thank you very much, Dr. Parashram and Dr. Hines. There's one more question. Dr. Abraham is asking, do the monkeypox lesions heal with or without scarring? Dr. Sweet? Or Dr. Edwards?
I mean, they generally heal with scarring.
Let Dr. Edwards take that one.
They generally heal with scarring, pock mark scars. Again, depending on the depth of the lesion. So if it's very superficial, may not heal with too much scarring, but if it's a deep lesion, tends to heal with scarring, pock mark scars as they described.
Okay, thank you. Any other questions?
I have one for Dr. Hines. Dr. Hines, what's the potential for this virus to become a pandemic?
So I would jump in there. I would caution Dr. Hines not to answer that question. But I mean, at any rate, I don't think anyone wants to make that sort of prediction, especially seeing what has happened with COVID-19 in the past. It is really an uncertain sort of future as it relates to the reemergence of diseases, especially diseases, and especially with the potential to mutate as we have seen in the past. Really and truly, as you said yourself, CDC has said that the potential is not there. But that is based on the historic behavior of the disease in its endemic countries. This by itself, having a disease spread in a way that we haven't seen it spread before, it's a unique event. It's a public health emergency of international concern for sure. So what happens in the coming weeks or months will give us a better sense of what will happen in the days or weeks to come. But to make a prediction as a public health physician in the year 2022 will be a little dangerous ground to stand on. So I will I would say cautiously that we wait and see. The things that give us hope, as you said, it's not very easily transmitted from individual to individual. It is known to have spread by close contact from one person to the next. Very similar, the respiratory droplet infection tends to occur when you have mucosal lesions in your mouth or in those areas predominantly. They're trying to establish whether there's asymptomatic spread and to what degree spread occurs. So that period where you have spread of disease is thought to be when you actually have the rash occurring or early symptoms. So again, we're still looking to see if you're having asymptomatic spread and what asymptomatic spread, if it is confirmed that there is asymptomatic spread or spread as a prodrome like you see for COVID-19, then of course it lends itself to epidemic spread in a much shorter period of time. So until those pieces of evidence come to light, I don't think predictions are the way to go from our perspective, at least at the Ministry of Health.
All right, thank you very much for that response. I'm seeing another question asking, are the antivirals readily available from CDC?
Yeah, so we have been in conversations with CDC. About 2 weeks ago, we started to have conversations with CDC regarding the tecovirimat, and they have said to us that they will attempt to make it available through the country office of CDC. So that is one area of exploration for us. We have also reached out to the parent company to see if we can have purchasing directly from the company as well. I think the quicker route will be through the CDC mechanism, but we are in at least bilateral talks as well as through the CDC mechanism to approach to see if we can have those antivirals in stock, or at least if we do have a suspect case, that we do get them in as quickly as we can. I think the same thing goes for the vaccines. So we are in talks with both CDC as well as PAHO with regards to the vaccines. So PAHO is trying to source the vaccines for us as well, because normally we buy vaccines through something called the revolving fund of PAHO. So that is our normal mechanism for procurement of vaccines in the country and generally in the region. So PAHO has given us the assurance that they are pursuing through the Washington office as quickly as they can. And again, CDC is a backup in that regard to assist us in getting those vaccines here as quickly as we can as well.
Okay.
Dr. Hines, I see you have your hand up.
Yes, started talking while I was muted. Yes, my hand is up because now I have a question for Jeff. I'll actually put the question for Jeff and for Dr. Sweet with regard to maybe using some of what we put together, because we put a lot of information out there, but now seeing whether there is any group of considerations that we can look at to either preemptively or presumptively rule in or lower the index of suspicion for monkeypox with all these rashes that we're seeing. So we're not saying making a spot diagnosis, but we're saying which things would make us think more yes and which things would make us think more no among the presenting symptoms that that they've described.
So yeah, so I think Dr. Edwards and myself would have had a discussion early on this one. So at present, most of the RHAs have consultant dermatologists assigned to them, at least Southwest, Northwest, North Central. In North Central, there's also PCP2 dermatologies, and in Eastern region, there's registrars of PCP2 as well for dermatology. So the first line of call, at least in the public sector, will be to liaise with your respective dermatology departments as quickly as you can, utilizing telemedicine and other forms of virtual media as possible so that we can get a quick idea of what we're dealing with. But just being pragmatic about it at this point in time is that, as Dr. Hines would have indicated, the key to it is to isolate as quickly as you can while we're doing what we need to do to determine if it is a suspected case or not. And then, of course, afford the best treatment for those persons as quickly as we can. So the dermatologist, and I think Dr. Sweet would have mentioned as well, to get the person to a dermatologist as quickly as we can as well. And a lot of the differentials tend to be highly infectious as well in the early stages: chickenpox, impetigo, a lot of the others that tend to look very much like it will be infectious as well. So it will all go well hand, foot, and mouth, for example, to have those people isolated whilst we do what we need to do, meaning sampling, confirmation of diagnosis, and all the lot. So if Dr. Edwards or Dr. Sweet wants to come in, that's fine as well to add it.
I mean, in terms of genital lesions, you'll want to rule out the STIs as syphilis. We currently have a little mini epidemic of syphilis among men who have sex with men. So, I mean, but syphilis can be easily diagnosed. Again, we can do the VDRL and TPPA, so we can, at least diagnose syphilis. Herpes, we actually have the PCR available to diagnose herpes, so we should be able to diagnose herpes simplex, and well, zoster is easily diagnosed clinically. So again, history, physical examination, investigations for the common conditions. And I mean, as Dr. Parasuram said, if you're ready to suspect a case, put that patient in isolation while these investigations are being done.
But as I mentioned, I think the one thing that might come up soon is this hand, foot, and mouth. Because I think already some cases are appearing, and there'll be a sort of a public response, especially since they've been seeing the photographs of the of monkeypox with these blisters on the limbs in particular. So expect that you're going to get some kind of response in that direction. But that's why I mentioned that the history is so important as well, because, the way things evolve, what did the rash start like? What was associated with it? Was there a prodrome? That kind of thing, I think will help people to sift out the issues. So things that are more sort of a long-term, when we get into those immunobolus disorders like pemphigus and pemphigoid, it's not going to be an acute history. The drug eruptions are going to be fairly acute. You may have a very sick individual on your hands at that point where dermatologist has got to get involved anyway. So I think these are some of the things that will help people to sift out the cases.
Okay, great. I hope that answers your questions. And obviously that was a question I wanted to ask too, how soon to do the referrals to the dermatologists and who would be our point of reference. So thank you for clarifying. I think there's one more question, at least that I'm seeing. Someone notes, they said it would be easy to assume this would be chickenpox. They wanted to know if there was any role or efficacy for valcyclovir, etc., in the treatment of this.
Again, remember valcyclovir is for herpes virus, so this is a...
Okay. Okay, no problem. Somebody asked, okay, if auto-inoculation is possible from scratching and rupturing a vesicle, and if so, could we prevent or reduce this? Right, and at this point in time, I just want to give a reminder. This meeting this evening is actually being accredited by the American Academy for Continuing Medical Education. So for those of you who are interested, members in particular, and also non-members, just copy and fill out the feedback form, and you can actually have CMEs for tonight's event as well. So we wanted to thank persons for participating in the CME that's hosted by T&TMA on behalf of the Ministry of Health. So if there are no other questions, because I know we're running close to 7:45, and I know it's been very interesting so far. If there are no other questions, I would like to invite Dr. Martina Rodriguez to give our vote of thanks for the evening.
Hi, good evening, everyone. Are you all hearing me? Marissa, are you hearing me?
Yes, I am.
Great. On behalf, first of all, I would like to apologize for my camera being off, but on behalf of the Trinidad and Tobago Medical Association, We would like to thank all our presenters. First to begin, we would like to thank Dr. Parashram for involving us, the T&TMA, in this most needed informative meeting on monkeypox virus. We had a successful meeting tonight with maximum attendance of 100 who logged on. Secondly, we would like to thank Dr. Jeffrey Edwards for his clinical presentation on the virus. Dr. Sweet, we will also like to thank you for taking us back to basics, and most importantly, for also expanding on the most difficult diagnoses for persons who are also general practitioners who may not be familiar with the blistering disorders. And we do know what SAGO is. I actually made that yesterday, actually. Dr. Avery Hines, we would like to thank you for giving the public health approach, and we are looking forward to you keeping us updated on the reporting of if any cases occur. And Dr. Nimrod, we thank you for hosting the meeting and for all the doctors who attended. Thank you. Everyone have a good night.
Thank you very much, Dr. Rodriguez. And thank you once again, everyone, for logging on. Thank you very much to our esteemed panel and Dr. Parashram for making this happen. All right, so have a great night and we'll see you for our next meeting. Thank you, everyone.